Welcome to the Voices of Impact podcast, where we engage in spirited discourse on the world's most pressing issues with the goal to discover and implement solutions. We are an ambitious youth group, and we will not settle until we have tackled every challenge our world faces.
Previous generations have left us with a host of issues, but the world is ours. Join us as we learn life lessons and how to contribute to a more fair and uplifting planet. We will take the torch from older generations, learning from their mistakes.
We will glean wisdom from the experiences of adults who tried to prevent us from ending up with the issues that we face today, as well as the experiences of adults who, to this day, stand alongside us, fighting the southward progression of many spiraling dilemmas.
Tune in weekly as we approach these many quadrants through the lens of the United Nations 17 Sustainable Development Goals, or SDGs, for the planet. Voices of Impact is brought to you by the University of San Diego's Jacobs Institute for Innovation and Education, PPC Profit Pros, and SchoolCAST, a Cloudcast Media program to empower the voices of young students around the world.
This is our first official episode of Voices of Impact, and we could not be more thrilled to kick it off with an SDG that is so prescient to the general populace. SDG 3, Good Health and Well-Being. I'm Shane.
I'm Isabella.
And this is Voices of Impact.
Since the kickoff episode, we've all been buzzing around behind the scenes. SDG 3 really gets to the heart of so many issues like poverty, education, and even climate change. So, we're starting big.
And not just big, personal, because health is something every single person experiences. And today, we're lucky to have someone who's spent decades rethinking what healthcare can be, and was also involved in the 911 dispatcher system.
He's been a thought leader at the Hastings Center. He's advanced ethics and human dignity in medicine. He co-authored Pluck, Lessons We Learned for Improving Healthcare and the World, with his identical twin. And I've enjoyed reading that book myself. Oh, there it is. He's been an advocate for patient experience and health equity. He's blended policy with compassion. He is a true visionary who sees health as a human story, and it must include everyone. So, without further ado, Mr. Blair Sadler.
Thank you, Shane.
Looking through your experiences, it's chilling, like all the things you've accomplished, being the CEO of Rady's Children's Hospital, for example, being this power duo with your brother, Mr. Alfred Sadler, and, working on the Uniform Anatomical Gift Act to climb the ranks. What kind of advice do you have for us and for other youth?
I think the main reflection I would share and the advice I would share is my career has not been a straight line. It's not been a linear progression. In maybe my era, but even before, you might start working at a company and plan to work there for 30 years and kind of go up the ladder. And if you worked hard and were smart, did well, and then ultimately you could be in a senior position or even a CEO. That's kind of the traditional, probably old-fashioned model of career progression. And in my case, it was much more of, I'm not a sailor, I don't own a boat, but people say, unlike, the shortest distance between 2 points is a straight line, right? We all know. But in sailing, when you're trying to get from, let's say, San Diego to San Francisco, it's not a straight line. You're tacking. You go to Catalina, and then you go to wherever. And that's more the way my career went. After college, I graduated from law school. I wasn't in healthcare. My twin brother, when he was 5 or 6 years old, decided he wanted to be a doctor because of a doctor who visited us when we had really bad earaches and gave house calls. And he said he was a very kind, empathetic person. And he said, I want to be like him. That's who I want to be. I didn't have that sense through college, and law school was more an opportunity to broaden my awareness and thinking, but no real idea what I wanted to do with it. And then we're in Philadelphia, where this story of collaboration really begins. He was in a surgical internship at Penn, and I graduated from law school at Penn and was clerking for a judge. And we started comparing notes about what's it like in medical school versus law school and how different they were, and started brainstorming, thinking about, we're 25 years old, okay, 24, 25 years old. What would it be like to try and work together on something? And as we talk about in the book, we tried something, and that would be one of my suggestions for you guys is you try stuff. You try stuff, just like you're doing with this great experience together. I mean, here are 3 or 4 of you who I gather from just what you described and what Charles has mentioned, didn't ever know each other a few weeks ago, and now you do. Now you're collaborating, you're writing a script together, you're interviewing people together, you're learning together, even though you're in Iowa and San Francisco and San Diego. That's pretty damn cool, right? And so you don't all have to be majoring in the same thing or going to the same school, right? It's a very typical modern day example. The Good Samaritan problem. Everyone's heard of the Good Samaritan from the Bible, right?
Mm-hmm.
Stop and assist someone. And the Good Samaritan, as it's related to in healthcare, is typically stopping someone at a roadside accident and helping them out. And the legal ethical question was, what protection or even immunity should there be if a doctor or a nurse or anyone stops at a roadside and tries to help, but the person either still dies or doesn't do well, and there could be a fear or reluctance to help because I might be sued, or I'm not a doctor, And so that seemed like a cool issue, and my brother had a requirement to give a presentation at Mass General Hospital, where he was doing a rotation in Boston, Massachusetts General Hospital. And he said to the chairman of the Department of Surgery, I'd like to try my presentation on this problem with my brother, as opposed to a very medical or scientific technical issue. And Chairman Paul Russell was his name, said, yeah, let's give it a whirl. So I flew up to Boston one afternoon at, say, about this time, it was around 5 o'clock, in a small auditorium with maybe 30 or 40 people. I was the only person that wasn't wearing a white coat. And my brother and I talked about this issue. And we had done our homework, we had done our research, and we found out that there was tremendous variety between the various state laws about the Good Samaritan problem. Some say this, some say that, and kind of laid out what the issues are. And then we had a great question and answer period of, what do you think? And before you know it, it just seemed like it was 5 minutes. It was over. It was a lot of fun. And at the end, we talk about this in Pluck. At the end, we talked to Dr. Paul Russell and he said, this is one of the best grand rounds we've ever had. It was very different. So what's the takeaway lesson from that? Try stuff. Ask people for permission, sort of not forgiveness. Charles knows this phrase, run until apprehended. If you're always waiting for permission, you're going to often be sitting waiting, and it passes by. The world passes you by. I don't mean you're reckless or careless, but you try stuff and you try new things. And one of the first lessons of Pluck, of the 15 lessons, the very first one is start where you are. Start where you are. And number 2 is grow from rookie to expert. So when my brother and I started learning about the Good Samaritan problem, we were complete rookies. We didn't know what the laws were. We didn't know what the rules were. And it's doing research, learning. And I wouldn't say we were an expert by the time we gave this presentation, but we certainly knew a lot about what the different laws were, and we'd given some real thought to what makes most sense, right? And by being willing to put in that time, discover new things. I really don't know anything about climate change. And it's easy to think of, well, I'm not a climate scientist, or that's not for me. Start where you are. What part of the climate interests you? Is it the science? Is it the messaging? Is it the advocacy? Part of that. And that's where doing your homework is so important. So the 911 example that Shane mentioned, later on having gone to the National Institutes of Health and had our first opportunity to work together as a medical legal team. That's what we were hired to do. We're now 26 years old. 26 years old, and was on organ donation and transplantation. Could have been something less boring, more boring, or not as interesting. We were lucky. So part of pluck is luck, persistence and luck. That's when the editor was thinking, we're scratching our head, what's a good title? He came up with that at some point, and was like, oh, that sounds good, So it's a combination. Weren't you guys lucky that happened to be the first thing you were asked to do? Yeah, absolutely. But if we hadn't pushed and been persistent to apply, we never would have had the chance. Similarly, we're now at Yale in the medical school running this Yale trauma program based on the Department of Surgery chairman, a different guy named Jack Cole, who invited us to come up. What did we know about trauma and emergency care? Nothing. Zero. Rookies. Started from zero, just like organ donation. But as we got into it, and why the chairman of surgery, Jack Cole, had gotten a major grant from the Commonwealth Fund, a foundation in New York, to study this, was it was being widely recognized that the pre-hospital system of emergency care and trauma was a complete wasteland. Let me give you an example. Was there a 911 number to call? No. Well, if you're in New Haven, Connecticut, or San Diego, California, and you were in an accident or you saw someone in an accident, what number would you call? The yellow pages, the white pages? I mean, give me a break. But that's real. That was reality. You dial operator and get referred. There was no central number. 911 was just being approved. And when we did the statewide study of Connecticut, only 14% of the state had 911. So that was happening. But there were no EMTs. There were no paramedics. It's hard to believe. The dispatcher knew what to do with a fire emergency or a police emergency. But what about a medical emergency? What if a mom calls and said, I think my 5-year-old or 4-year-old may have just eaten something poisonous in the kitchen by mistake. What do I do for a poison for a 5-year-old? They wouldn't have known.
Mm.
Right? Whereas if you call 911 today with that kind of medical emergency, they'll know how to give you first response. They're not doctors, but they've been trained in medical emergencies as well. We take it for granted, right? Ambulances. They weren't these sort of mobile hospitals on wheels that we see everywhere, right? They were station wagons. Sometimes it was even a hearse. Sometimes the company that ran the ambulance system, believe it or not, was also the funeral home. And there'd be sort of jokes about, do they make more money if the patient dies or lives? But seriously, what does that mean physically for caring for a patient? In a station wagon, you can only have one person in the back, if at all. You have no room. There's no room for any telemetry or anything like that. And there was no direct radio connection between the ambulance at the scene and the emergency department. So they could not be talking as we do every day. They call in and say, this is what I'm doing, getting more approval. Last thing, there was no specialty in emergency medicine, believe it or not. ERs were staffed by internists or surgeons who were working part-time. So you had no idea who you were going to get on a given day. And there was no trauma system. So as Shane knows, in San Diego, there's 6 designated trauma centers, 5 for adults, 14 and over, and 1 for kids, which is Rady Children's. What does that mean? That means that those 6 hospitals have extra training of surgeons and nurses and intensive care to deal with traumatic injury, whatever that could be a fall or an auto accident. So of the 30 hospitals in San Diego County, you don't just go to the nearest hospital in a serious accident. You go to one of the designated trauma centers, and you're treated at the scene by a skilled paramedic who can talk directly to the hospital. All those steps, I know I went on a long time here, Shane, but it kind of gives you a sense of there was no single silver bullet that changed emergency care from kind of a wasteland to this amazing part of healthcare today. It was a series of lots of different pioneers who were working in different cities around the country and making things better. And that's what we found in Connecticut. We were able to put a statewide committee together of the fire chiefs, the hospital association, the medical society, and come up with a statewide plan to improve emergency care in Connecticut. And we published a book called Emergency Medical Care, The Neglected Public Service. The Neglected Public Service. That was about 50 years ago. And we called it that because compared to police and fire that had real other public services in healthcare and law enforcement that had well-developed systems, this was neglected. It was just like, good luck, not true anymore. Okay. Well, I guess the other thing that happened during this period, two other things. The height of Vietnam, this is really important. And there were well-trained Army medics in the Army who were in the field in Vietnam, in trauma centers, in tents. You see it on the movie MASH. That was real life stuff. And they were saving people every day in terrible situations because they were so well-trained and had trauma centers. And we weren't doing it back home. Like, what's wrong with this? People started recognizing this. And the last thing was the power of TV. There was a very popular TV show, Charles will remember, called Emergency, with an exclamation point. That was the name of the show. And it was all about these cool paramedics based in LA that just so happened. But they're just like exciting shows with in emergency rooms or police, right? In this case, it was about paramedics saving people's lives. And that was the first time a lot of people ever said, oh my God, look what they just were able to do. And that got to be popular, and people thought, oh, if they can do that in LA, maybe we can do it in San Diego or in Philadelphia or Des Moines, Iowa, you know. So that's a long-winded answer, but it's giving you some examples of things don't just happen from A to B to C. It's sometimes putting things together and asking for help and having conversations with people. And then trying stuff.
Absolutely. I mean, and I think what I find particularly inspirational about your journey and your brothers is, as you said, you weren't qualified in the specific challenges that you ended up taking on. But as you said in a podcast I was listening to, and then also in Pluck, like you have you had to hit the books, you had to research, like in terms of the laws regarding pituitary donations in morgues and whatnot, and you made it happen. Perhaps there were people that were better specialized in certain things, but because of your persistence, like luck, the persistence element of that, you were able to revolutionize the health industry. And I think that is such an inspiration. Especially, I mean, it's already cool enough that you have an identical twin, but that you were able to do all of this with him. I wanted to also mention how you were saying in the book that after one match, you decided not to compete anymore, but to work together, and you were able to train each other. That led into that definitely led into your dynamic as you took on these various industries and advanced healthcare in so many regards.
Shane's referring to when we were 14 or 15 years old, Allentown, Pennsylvania, discovering tennis, and started going on just hitting the ball around. And instead of trying to beat each other, we kind of realized after one 90-degree day, we're sort of sitting there saying, why are we trying to beat each other's brains out? Why don't we help each other? And sort of, I'll be your ball machine for 10 minutes and hitting forehands, and then vice versa, and collaborate. And that allows your collaboration with other people rather than always trying to compete. Allows you to learn exponentially faster, right? And trying stuff, just as you guys are from each other. That really was a game changer in terms of a mindset, So there's a lot of people talk, what does make America, why is America so competition? You got to beat the other person. Well, there's a value to competing and excelling, but in terms of impact and social impact, I would suggest collaborating is a much more powerful mindset. And then, so back to Children's Hospital, which was part of your question. as you can see, I didn't really have a plan to end up working in a children's hospital, and came out to Scripps Clinic here in San Diego when I was 36. Remember, I'm not a doctor. I don't have a master in public health. I'm not a nurse, but now I'd had 9 years of experience doing a bunch of different stuff in healthcare. So I knew my way around pretty well. And I thought adopting a leadership role in a hospital might be kind of fun. So I was trying a new thing at Scripps Clinic. And then when I was 39, I had a chance to move to Children's Hospital as the CEO, which was just one of those sort of fluke things that opportunity came up, and keep your eyes open. And I think part of why I ended up being given the opportunity to do that was that I'd had this variety of experience in very different situations.
Yeah, ladies and gentlemen, Blair Sadler. Collaboration here. That's what the UN is all about. I want to get into SDG 3 specifically. So for SDG 3, the UN's official statement is to ensure healthy lives and promote well-being for all at all ages. It doesn't really narrow down the goal, so we wanted to kind of break it down into 3 segments that we want to discuss today. So first, we'll focus on ensuring healthy lives, especially through prevention and safety. Then we'll get into promoting well-being, especially mental health, and how design and experience can help. And then third, we want to get into health at all ages, so equity and social factors that can shape health outcomes worldwide.
So, Mr. Sadler, since you've worked across, hospitals, policy, and even the arts, how do you feel about the UN's goal? Is it realistic to aim for health and well-being for literally everyone, no matter where or how old they are? Or are there, some crucial hardships that we have to overcome first before we can hope for worldwide health and well-being?
I think it's one of those North Star goals, Isabel, that you want, that is where you're going, where you aspire to be. You may never reach, if you literally mean health and wellness for everyone, regardless of age and where. We're never going to get to that. That's sort of perfection worldwide. But to have that as a mindset, I think can be very compelling. Then I think it's a matter of breaking it down and saying, well, where do we want to focus our energy? Either by an age group or a particular illness or a particular part of the world that's underserved more than others, and really being selective and focused within a larger goal.
Okay.
I like the idea of it being a North Star, because if you navigate toward the North Star, you never actually land on the North Star. But it's a noble goal. Let's get into segment 1, which is prevention and safety in healthcare. What occurrence is more devastating and preventing of life than infant mortality? It's a macabre topic, but I think it's very important to get into because a lot of places are really lagging in this development, and we could learn from you. For example, in Sierra Leone, only about 1 in 10 babies are born with the assistance of a healthcare worker. And as you would expect from that, they have very high mortality rates. This is just one case of many. How do you think we can alleviate such statistics with good medical care in less developed locales? And can we utilize statistics that are sad like this to impress the urgency of healthcare infrastructure in developing areas?
Well, I think, and to take your second part of your question first, I think we clearly can, and people are doing that. I think the AID program that unfortunately just got canceled, I think is a tragedy, because that particular program, but there are many others, the Red Cross, Doctors Without Borders, amazing organizations with the UN itself, UNESCO, and are very targeted at saying, okay, we're going to go after infant mortality. I'm not an expert in this, so I'm just speaking generally, but we're going to go after infant mortality. What are the 10 worst countries that in the world, or where could, like your Sierra Leone example, where we should really focus our attention, because we can't work at 100 countries at once. And then what has worked in the past? You can't have doctors in every street corner or you have hospitals fully developed, but there are all kinds of people who are pediatrician and are neonatologists or pediatric nurses practitioners and work with infants can tell you, can rattle off what are the 3 to 5 most important things that a country or a community needs to have in place to reduce unnecessary infant mortality. What are they? And I don't know what those are, but I would just guess that, some of them are, a lot of it's a healthy mother. So if there are problems of malnutrition, which there are, and so the mom and baby during pregnancy are malnourished and not getting fed well, the chance of infant mortality goes way up, which has nothing to do with the surgery or the actual delivery of the baby, right? Another one would be knowing the relationship of fetal alcohol syndrome and drugs, that if a mom during pregnancy is on drugs of various kinds, that will affect the well-being of the baby, even potentially prevent them from being born alive. So, it's really, there's where the research, right? Where do we start? Start where you are, rookie to expert. Like, this isn't the first time this important question has been asked. This isn't the first time someone's rolled up their sleeves and said, I want to work on this. What's worked? You go to the literature, podcasts, YouTube, and find out. And within a week or 2 weeks, you can know one heck of a lot about examples around the country. And now can kind of have a portfolio and say, if I have an opportunity to work in Sierra Leone for 6 weeks. I just made that up. But that's like, I have a chance to go to NIH in Bethesda. Here's my first assignment. So you get an assignment just like that. We're going to be in Sierra Leone. I'm going to work on infant mortality. What's going on now? But what are other low-income countries? What are some success stories out there? And pick 2 or 3, not 30, 2 or 3 interventions that can really make a difference. It'd be like, well, what if we all had a 911 number to call instead of fumbling around when life is being threatened? That would make a difference. Or, well, what about if we trained the person at the ambulance scene to really know how to start an airway and how to stop bleeding? Oh, that'd be cool. Let's go do that. Oh, there's a course, 81 hours that the Academy of Orthopedic Surgeons already created. We don't have to start over. Go find that and teach that to, pick a number. I want to train 100 people in one community in Sierra Leone, the 81-hour course, so they can treat people in the field. You pick stuff. And if you look at the Uniform Anatomical Gift Act in terms of the organ donation, we didn't try and solve every problem at once. What we did want to do was, how do we make organ donation as simple and easy as possible? Well, let's, first of all, be very clear that any individual who's 18 and over has the right to decide upon their death that they want to be an organ donor.
Right.
Okay. And what if they haven't made that decision? Well, then it's the family. Well, who's the family? Is it the mother and father? Well, what if there isn't one? Is it a brother? If there are 5 brothers and sisters, what do you do? Really getting it simple. And well, what about putting it on an organ donor card the size of that can fit on a driver's license? That sounds pretty cool. And that wasn't our idea when we did that. The Maryland Eye Bank had one, or the Kidney Foundation in a particular state had one. What we did, and we talk about it in the book, was by then we were pretty well known in organ donation because we've been involved with writing this law. And being at NIH, we had a platform. So there was a meeting that a committee called that we chaired at the National Academy of Sciences in Washington. And just picture this. So we're in this auditorium with about 40 people. We're 27 years old. but we'd written by then these major articles in the New England Journal of Medicine and the Georgetown Law Review. So if people was like, who are these guys? It's like, well, they're pretty young, but they seem to know what they're doing because they wouldn't have had an article published, a well-written article published in a prestigious medical journal. I guess we ought to listen to what they're saying. And so we then had people from the eye banks, the Kidney Foundation, the Heart Association, even the funeral directors, all coming together. And the only thing we said was, it's now 9 o'clock in the morning. When we finish at 4:30, we want to agree on one thing. We're having one card. We're having one card. You can put, and it says the same things on it. You can put Eye Bank of Maryland on it or Heart Association of Virginia on it, but we don't want to be sitting here in Virginia, Maryland, and the District of Columbia and having three different cards. And if someone is born in Virginia, but they happen to be in Maryland and they're in an accident and now they're a potential donor, well, you don't want to have surgeons and nurses running around, is this valid or not, right? So you kind of looking at a complex problem is trying to simplify it when you can. You can't always do it, but what one step could we take? Okay, make it really clear, give people a choice. They can select a particular organ or say any organ. Okay, A, B, C, there's three choices, and sign it. Now, I mean, that's sort of the dark ages, but now there's, of course, computerized registries in every state. So you join the registry and there it is. There it is. So you're now.
That's the uniform donor card. You have gone into new industries and switched things up, and they're like, who is this guy? Who are these two? And you're able to teach them stuff because you're a connector. You're I don't remember exactly. There were three things that you talked about in your book: a connector, a maven, and something else.
Salesman.
A salesman. And I think you two, you kind of played those different roles throughout your life. You were all of the above, I would say. But going back to the idea of like trying to change things up in a place like Sierra Leone, how do we, like, they already have their own culture there, and how do we give them advice about how to be more healthy without them being like, who are these guys? Why should we listen to them? And without them feeling, kind of taken aback by the new medical advances. Like a perfect example is the medical advances of heart surgery started by Christian Barnard with the first heart transplant, and people were like, look out, like Barnard's coming for you, like crazy bumper stickers like that. And there was a lot of paranoia that maybe hospitals would give up and transplant your heart if things are looking bleak. There's a general fear of advancement. How do we respect that, as you did with your UAGA organ laws, and how do we respect that while also pushing for advancement that save lives?
Yeah, I think the transplant one, we talk about it in the book. There was various cartoons in the New Yorker magazine or New York Times or whatever, and one of them was a bumper sticker that said, "Drive carefully, Dr. Barnard may be watching." And another one was a patient in a bed in a hospital with a big board over them saying, "Patient asleep, not a heart donor."
Not a heart, yeah.
So those are both kind of funny, but the point was, and the reason we included it is that those were a reflection of general valid concern. Is that a potential risk? And so how do you deal with that straightforwardly? And in the law, first of all, being an organ donor is completely voluntary. And everything is around a voluntary decision. There's no one putting a pressure on you or paying, like in China and places you read about prisoners being used as organ donors and people paying for organs. So when you start, this is a voluntary donation either by the person themselves or their family, number one. Number two, we actually put in the law, I think it was Section 7B, as I recall, it was a while ago, about the conflict of interest chain that you mentioned people were worried about. Well, is someone likely to give up on me early if I'm in a transplant center because there's a potential organ recipient of my heart down the hall? And so we made it very clear as a matter of the law, and we got a lot of input from surgeons and what's the right ethical thing to do, was that the doctor who is treating and responsible for the potential donor has to be a different doctor than that one treating the recipient. So you take a complicated issue and you put it down into one sentence, and it's something everyone can understand, and that provides reassurance. So I think that's a good example of you kind of listen. A lot of this is about listening. A lot of this is about listening. There's a lot of worry out there that people are actually going to be given up on. I didn't know. So what do we do about that, right? We'll make sure it's voluntary, and we'll make sure that you have to be registered, and we'll make sure there's not a conflict of interest. Those kinds of things.
Mr. Sadler, you mentioned that small changes can make a big difference, right? For example, in Vietnam, they did something really cool that maybe other countries could copy off from. So they set up a simple, affordable birthing center with trained midwives in villages. And because of that, infant mortality dropped by half in less, maybe just 10 years. You said that listening was also a big role. How do you think we can make other countries listen and actually take our advice without worrying about things like, conflict of interest?
It's a great question, and that's a great example of how a country that is not wealthy, that doesn't have as many doctors as the United States, Europe does.
So I
Figured
was
out how to
also
deal with the problem
thinking
and
that
learn it from them.
since we're talking about,
But you got to find the three things that Shane mentioned about were, are you hearing me?
Yes.
Okay. That Malcolm Gladwell said in Tipping Point. So salesmen, mavens, and connectors. So if you're going to go into a different country, who is the connector? Who knows people of influence in Sierra Leone? Because if I come in no matter how smart I am or experienced I am from Vietnam or from the United States or wherever, say, well, here's what we did and it worked. You ought to do the same thing. You need to have a receptive audience. Who is that? Who are those thought leaders? And then they can become the salesman for the idea, right? And the maven part, somebody who really knows what the hell they're talking about. Not, I read this cool article somewhere, but somebody who actually did it and worked with families in Vietnam and saying, here's where we were in Saigon or whatever 10 years ago, and here's where we are now. And can tell that story as a maven, as an expert. So go from rookie to expert, right? So I think that's how you do it.
So from your experiences that you've told us, from all your overall general career path, you said that you've taken a lot of twists and turns, and that you've just been through basically every single experience you can in your field. So from what you've seen, from your expertise, I wanted to ask this question. So what are some causes of death or injury that don't get enough attention in your perspective? How could health systems catch these problems early before things get really bad?
I think a lot of basic things like immunizations and vaccinations, making sure that those are done on schedule and in all kinds of poor communities as well, is really important, and making that as easy as possible to do. Respect in science, which right now is under attack, unfortunately. So one of the key things is getting the message out in podcasts through various means of communication, thought leaders, some celebrities, or can be very, you've all seen this in different cases where a celebrity can be a very effective advocate, and figuring out who are the influencers Who are the connectors about an issue in a particular neighborhood? Is it ministers? Is it nurses? Is it moms? Who are Mothers Against Drunk Driving? MAD is one of my favorites. We talk about it in the book. So here's Christy Leitner, who I've never met, 35 years ago, driving with her 13-year-old daughter, either to or from a soccer game, and they're hit by a drunk driver, and she's killed. Her daughter's killed. And she is able to overcome that grief and channel that energy into creating Mothers Against Drunk Driving. But, how does someone do that? And where do they start? Do they start with try to change the laws about alcohol limits among drivers? Is it a PR campaign? Where do you start? My guess is she started where she was. She started as a rookie who didn't know anything about the details. She learned from, somebody in Iowa, the community, here's what they've done. I made that up, but certainly were communities around the U.S. that had a much more successful rate, much lower rate in this case, of deaths from drunk driving than others. Well, what did they do? And what were the main impediments, right? And so, it's examples like that I find very inspiring, where someone like Christy Leitner starts not knowing a single thing beyond being an intelligent, caring person, but about this detailed issue, but as a personal tragedy. But it doesn't have to be. It can be just like the three of you are. You're very interested in making the world a better place, and you're doing your homework right now. You're doing your R&D work, saying, what are issues out there that I might want to get interested in? How would I do that?
I like how you discussed that we need to look at what's already being done and talk to people. I mean, you focus a lot on people. And how do we learn from the mavens to go from rookie to maven ourselves? It's like how you talked with Mr. Stason, who was sharing the ULC committee that had been working on organ donation. And I'm just wondering, like, how did you apply these lessons from all your experiences with your brother going from rookie to maven and also the other to how did you apply that when you were the expert? You were already like the head of Rady's Children's Hospital, and with all the ideas, with all the knowledge that you had picked up, how did you apply that to such a high position when you were used to kind of starting from the bottom and working up? And what were those politics like, and what did you do with all that power?
I think one of the things that question, one of the lessons of the 15 is lead from any chair or lead from anywhere. You can be a leader without being the CEO or the dean of the medical school or the chairman of the department or the head coach of a sports team. And the main thing is learning as you go. One of the ones that lesson 3, find and develop your voice. One of my favorites. Find and develop your voice. Barack Obama was not a great public speaker when he was 7 months old. How did he do that? He developed it, right? And the poet who gave the poem at President Biden's inauguration wasn't a poet overnight. She started writing poetry when she was 14, right? That was her voice, both in writing and speaking. So I would say that, to get back to your question specifically, I think by the time that I was interviewing for this job at Children's Hospital, the fact that I was a good speaker and could communicate effectively was a big asset. And the fact that I was a good writer, by then I'd written 2 different books with my brother on different topics, physician assistance and emergency medical care. I'd written a bunch of articles on organ donation and transplantation. That helped. But also, in terms of my experience in leading and bringing people together in different situations, people could see who were on the search committee to say, well, if this guy's done these things in these other areas and he can understand how to translate them into things we need, well, that's pretty attractive. We ought to go with it.
And one of those things that you brought to Children's Hospital is a real personal touch, I would say. Like, we hear about the stats about like how many patients are having certain issues and complications and all the medical stuff, but you also focused on how they feel in their space. And I do have like a potential qualm with that, or something that I wanted to ask you about, because there's a hospital that I visit here in San Diego, and the space is so grandiose and magnificent that I kind of wonder if they could have cured cancer with the amount of money that the architecture costs. So how did you balance making patients feel better in their space with the finances that were required in working on, patient care in terms of a more medical standpoint? And how do you deal with board politics as you transition the company, or as you transition the hospital in a different direction?
So, Shane, you asked me about 18 questions.
My fault.
No problem.
I'm really curious about this.
Is seriously on the architecture design part, if it's a very fair question, and there's a whole science, as I learned when I went from rookie to becoming really an expert about what architecture and design and how it affects patients. Not because I was one, but I'd read all the literature. I talked to a lot of people. The idea was not to have grandiose lobbies with fancy marble and skylights and look how much, and winning a Frank Lloyd Wright Architecture Award, but creating spaces that were quiet rather than noisy, and single patient rooms rather than having 4 patients in a room, and having places that were quiet and locating nurses' stations further away from where the beds were, having infection programs in the air filtration systems that reduced any kind of transfer air through the air for immunosuppressed patients. Those are all things that directly relate to improving care, of which there were studies that showed this. So that's part of doing starting as a rookie and reading this stuff and saying, oh my God, this hospital in Indianapolis actually saved the number of infections or patient falls because they designed the patient room better. They made the doorway from the bedroom to the bathroom wider so 2 people could assist a fragile patient in and out. And why is that important? Because 40% of falls in a hospital and by patients occur between the bathroom and the bed, or the bed and the bathroom. And this hospital actually reduced patient falls by 90%. Wow, that's not just someone trying to win an award. That's cool stuff. Why don't we make sure we do that, right? So it's really basically the same formula of doing your homework, and you can avoid, getting into the politics. It's very fair. There may be an architecture firm or that wants to be Frank Gehry and build something fancy, but then that's dealing with, wait a minute, what are we about here? And we're a nonprofit hospital, and we should be using money and raising our money to really make a difference in patients' lives, not winning architecture awards. So that's the balance. Yes.
Yeah. So I wanted to go more into the architecture part. I was just wondering about what about the people inside of your children's hospital? Do you think that the staff has like a huge impact on the people you're working with and your patients? Because that's what I would think. So what would you think about that, Mr. Sandler?
They sure do. They absolutely do. And so part of the architecture connection is not only on patients and families, but it's on the staff. And if the layout of the nurse's station is very noisy and very cumbersome to work in, the fatigue and errors can go up rather than staying lower. So really doing analysis on architecture and design on the staff is really important. One of my favorites that I wrote about in some of the writings then was hydraulic ceiling lifts. So nurses have more back lift injuries, lifting patients, than construction workers. And here's a not a trick question. Do you think patients are getting heavier or lighter? What's your guess? Is this a problem?
Heavier or lighter?
Okay.
Heavier.
So the
Depends on
whole
the place.
right. So lifting a patient out of the bed onto a gurney to transport to the operating room manually versus having an hydraulic ceiling lift in the ceiling that comes down. We did one of the study, and Peace Health in Bend, Oregon, did this study, and they showed how before and after the number of nursing lift injuries in one unit, I think it went from 13 a year to 2. Another went from about the same number to 0. That's a massive saving. And if you're self-insured, as they were, that's cost that the hospital is also not paying, plus the days lost in work. So those are examples of really cool architecture changes that aren't based on winning awards, but saving lives and reducing harm.
I love it.
Mr. Sadler, as you probably know, a lot of health crises like, hospital-acquired infections or prescription errors aren't just about the lack of treatment, but about, breakdowns in safety systems. Do you think we've addressed this problem, or how can we ensure more efficiency or, better protection so this problem doesn't increase worldwide?
Well, I think it's still a major problem. And organizations like the Institute for Healthcare Improvement, IHI, based in Boston, it's a nonprofit organization, has really been leading the way on making improvements in systems of care to reduce hospital-acquired infections, for example. And they're now a global organization, and they're doing work, whether it's on infant mortality we were talking about earlier, or hospital-acquired infections. They're doing that kind of work all over the world. But it's like the North Star we talked about earlier. You're not ever going to eliminate to 0 and keep it at 0 any hospital-acquired infections. But you can certainly try and drive that number as close to 0. That's your North Star goal, right? Nobody should come into a hospital without an infection and get one while they're there. That's going backwards.
Yeah.
But it does happen every day. And it's not because they're bad people, it's just they're bad systems. And sometimes a lot of it is training, things as basic as hand washing, making hand washing easy. Here's an architecture design one that I discovered when I was working in this, is putting the hand wipe right at the front of the entrance to the patient room rather than further in. Well, that's so obvious. It's like, wait a minute, of course we should do that, but not everybody was doing that. So it's one of these sometimes simple things. Other things like putting in hydraulic ceiling lifts are more expensive.
All right, quick shout out to our sponsor for this episode.
Good Health and Well-Being, not a wellness brand or a fitness app. They didn't give us any money, but they promised something even better, a functioning healthcare system and lower mortality rates.
Which, let's be honest, is basically the same as cash. Like, if we do a good job promoting this, we might literally live longer. That's ROI. And then also, time is money.
Yes, real sponsors help you pay rent. This one helps you avoid needing a second mortgage for an ambulance ride.
Shout out to Mr. Sadler.
And if we play our cards right, we might even get universal access to mental health services, which, we all host a podcast. So thanks to SCG3, Good Health and Well-Being, for sponsoring this episode.
Back to the episode. Health is wealth, folks, and we're trying to get rich. We're on with Mr. Sadler. He was the CEO of Rady's Children's Hospital. Before that, he worked on the organ donation laws. He worked on the 911 dispatch system. He helped to develop bioethics to what it is today. All right, let's talk about the second part of the UN's goal, which is promoting well-being. There's so much discussion about how to boost well-being, but what if it were as easy as getting new lights? Hopefully, I've piqued the curiosity of the listeners and viewers, because I'm not joking. The Journal of Health Environments Research and Design says that giving patients control over their room lighting, it led to less stress, better sleep, and even faster healing. And the lights weren't even healing rays, just a sense of dominion in a world of uncertainty. So I want to start with one question. Why does something as simple as giving people more dignity and control make such a huge difference for their health?
I think part of it is we've all been patients with various things, and if you have more, and you're in a hospital, if you have more choice over what you can eat, what you can listen to, what you can look at, privacy, you're going to be a lot more comfortable and more likely to get well and fight your illness rather than fighting the noise and fighting the disruptions. And now studies show that, but some of these things are basically common sense. You go into a restaurant that's super noisy and you don't enjoy the experience as much as where it's quieter, or you can control your environment. It's certainly that's the case in the hospital.
I just want to say, you mentioned that, as you said, more control gives people more certainty, which can, definitely help, make them feel safer. So why can't more people, including those type of things in their everyday lives? Like, why aren't hospitals making life not only easier for themselves but for their patients? How can we make them understand that simple things like Shane said, lights, can make such a huge difference?
Also, I would like to add a little bit more. How can we make this in a super low budget for hospitals that can't afford something expensive?
Yeah, especially when it comes to redesigning healing experiences. How do we redesign a healing experience in a place that can't even, in a hospital that isn't really able to afford a lot of other expenses?
The things you can do is through volunteers. By definition, don't cost you anything. But having caring, empathetic people who volunteer their time. Children's Hospital use volunteers all the time, but all hospitals do, or most do, can make such a difference. Just someone who can listen to a patient, who can respond and say, I'll check that out, or I'll find the answer to that question, can make a very big difference. I do think most hospitals understand the basics about better environments, but some may not be able to afford some of the things we've been talking about.
According to the World Health Organization, nearly 1 billion people live with a mental health disorder, but most people don't get treatment. And even where diagnoses are rising, recovery often isn't. So we might not have an optimal mental health program, but how do you think we can improve that? How do you think we can make the biggest flaw turn into one of our best fields?
It certainly is a runaway problem. I do think in the last 10 years, I'm thinking mostly about the United States experience because I'm not familiar with the international experience. I think in the last 10 years, mental health has become more accepted as legitimate. The stigma of having a mental health problem and therefore the hiding it rather than coming forward has gone down. I think the awareness of the stress on patients and young people, and COVID certainly pushed that through the roof, right? A one every 100 years level epidemic. And so it was so disruptive of normal living patterns that it really pushed the importance of access to good mental health to the forefront. And I think a lot more investment is happening in mental health training and understanding and recognizing A lot of it isn't a medical issue. It's being part of a family. I mean, at Access Youth Academy, we've had some of our students saying, I had no home, and Access gave me a home. I had no voice, and Access gave me a voice. That's a direct quote from DJ, who was struggling in high school, was at Access Youth Academy, really worked hard, learned, but felt the stresses, the mental health stresses, go down because she was part of a community. Gets into the University of California at Berkeley, was graduated, is captain of the squash team, and is a real success story. That was because she had not 3 psychiatrists taking care of her or 3 mental health nurses, but she was part of a caring family, if you will. So, it takes a village. We all know the phrase. Helping people provide access to supporting environments is as important as anything else.
You mentioned awareness was something that was really big, acceptance in people's communities. You also mentioned that a nonprofit organization was making, the biggest effort and the biggest improvement in their field. You also mentioned the story about the mother and the teenage daughter, which I think is a story that really resonates with people. So, involving our listeners and our viewers, how do you think they can make a difference? How do you think, just increasing awareness, volunteering, service work, how do you think they can involve themselves into making our world a better place for everyone globally?
Yeah, it's a great question. I think everyone has to kind of look in the mirror and say, what do I care about most? And where do I want to make a difference? Explore, ask some questions. Start where you are and end up having done some exploration, reading, talking to people, trying things to say, I really want to work on X or Y, and I'm going to volunteer at a particular place, or I'm going to take courses in a particular subject and start a career. But it starts with self-awareness and self-discovery, which doesn't happen. That's the P in pluck. That's the persistence. That's the reading. That's the talking. One of our other lessons is, don't be afraid to ask. Ask people. It's amazing how many people, if you ask, I'd like to learn more about something, will be helpful.
So to the previous point that you made before about how important family and the people, your support system as a person, we talked about briefly before the show about how important friends are actually. And Singapore's mental health friendly neighborhoods trains everyday citizens like shoekeepers, baristas, and bus drivers to recognize signs of mental distress and guide people toward help. Do we really need to formally teach people how to look out for others?
I think that's a great question. I think the Singapore example is a tremendous one. That you don't have to be a PhD or an MD in psychiatry to be able to help people. So I think examples like that I sort of maybe heard about it, but I don't really know anything about it. I think examples like that and getting them out there and encouraging other communities and other countries to adopt some of those ideas is a good idea.
So this is kind of your idea of collaboration between multiple different places around the world to create, just a better mental health system, would you say?
Yeah, and I think that's what the UN's all about. And they have examples from over the last 50 years of where they've taken ideas and spread them to other countries.
All right, if you're listening and wondering how to help promote well-being in your own community, it could be as simple as organizing a walk group, checking in on your neighbors, or volunteering with a local mental health nonprofit. Every act of connection counts. Segment 3, health for all at all ages. So we talked a lot about keeping people healthy, but the last part of the UN's mission really brings it home, which is for all at all ages. It's a big promise, but in your career you've pushed to close the gap. So that includes for low-income patients, for older adults, for kids who fall through the cracks. So I wanted to start with this question. How do we design health systems that aren't just technically available to everyone, but are actually reachable and worthy of everyone's trust, that everyone feels they can take advantage of?
I think with difficulty, I guess I would say, but with commitment and persistence, and begin with the end in mind. If a hospital like Rady Children's says we really want to improve the health care of all children in San Diego, which is the 7th largest city in the country, well, what do we do? How do we do that? We don't just wait for the kids who come to us and do the best job we can. That, of course, we do. But what about looking proactively at various zip codes where infant mortality is higher, or juvenile diabetes is higher, or injuries going to school are higher, safe routes to school? We created something when I was there called the Center for Healthier Communities. And it really means just what the title says, this wasn't care to kids who were in Kearny Mesa in an intensive care unit at Children's Hospital. These could be kids in Chula Vista, in Mount Helix, San Ysidro, anywhere. And that would often mean getting together with the schools and the principals and the school teachers, or the county of San Diego. So that whole idea of collaboration that we talked about earlier really comes into play here.
Yeah. Another thing that also goes into collaboration, which is a really big idea, I think, in good health and well-being, is volunteering. And I actually have a really cool thing that I just found out about volunteering. So in Japan, they've got these community hubs where older adults volunteer to help run preschools. I found this really interesting because it reverses the idea of how younger people or kids volunteering at an older age home. So do you think we can apply this in cross-generational exchange of culture and aid to volunteering in healthcare? What are your thoughts?
I think it's a great example and it's a great idea. And absolutely we can learn from it.
So this is a bit of a personal question. I'm from Canada, and I like to talk about healthcare welfare. But hey, we may have some competition. So I was reading about Rwanda, and there's a national health insurance plan there that covers 90% of the population, including folks in remote villages, and it only costs about $8 a year. Can we learn from this in the United States, given that lower income citizens can become unhoused if they have a medical emergency?
We certainly can't. That's my answer. No, seriously, we have not committed to universal health insurance, which is an embarrassment. We don't start with, we say healthcare is a right, not a privilege, but we don't really mean it. And just this week, we made major cuts in Medicaid, which estimates are making 10 to 12 million people will lose health insurance. That's shameful. That's going backwards. That's going the wrong direction. So it really takes the will, the political will, to commit. And Canada has done a much better job of that than the United States. So I think when you're president of the United States, you can take care of it.
Okay, Mr. Sadler, this is the part of the show where we fully abandon realism. Here's a certified magic wand. It's hard to make out, but it's actually custom engraved with big health energy. Imagine you're standing in front of every policymaker on Earth. I mean, you pretty much are. This is Voices of Impact after all. What's one change you would make to all global health systems? I'm going to hand the wand over to you.
I would say that all healthcare, all decisions about climate were made with number one priority being the most positive impact on the environment and the health and well-being of citizens everywhere.
That was episode 1 of Voices of Impact. Thank you for tuning in. You can expect to hear spirited youth discourse in episode 2. We'll be joined by Dr. Perla Myers of the Jacobs Institute for Innovation and Education. A lot to look forward to as we dive headfirst into the United Nations Sustainable Development Goal on quality education.
We hope you enjoyed the Voices of Impact podcast, where we engage in spirited discourse on the world's most pressing issues with the goal to discover and implement solutions.
Our mission is to overcome global and societal conundrums through student unification, accepting our roles as future stewards of planet Earth. Please consider sharing this episode with other humans to enable spirited youth discourse on the planet's most pressing issues.
If you learned something or felt empowered by this episode, tune in Saturdays for more student-led change-making conversations, and be sure to follow, share, and positively rate our show.
Voices of Impact is brought to you by the University of San Diego's Jacobs Institute for Innovation in Education, PPC Profit Pros, and SchoolCAST, a Cloudcast Media program to empower the voices of young students around the world.